Welcome to Family Vlogs, and in this video we are going to discuss a very important topic in obstetrics. And before that, I would like to introduce to you a very wonderful book that each and every student should struggle to read, should struggle to have. And in this book is what I'm going to use in discussion of today. Now, this is a very wonderful book of 900 pages, and it's entitled National Guidelines for Quality Obstetrics and Perinatal Care. So if you are a student, do not fail to read this particular book. It's very important, and it has good summary notes that we are going to discuss today. And complications that may arise during pregnancy, or what we call obstetric complications during antenatal period. They are the following: antepartum hemorrhage, preterm premature rupture of membranes, preeclampsia, stroke eclampsia, abortions, ectopic pregnancy, multiple pregnancy, malaria in pregnancy, anemia in pregnancy, cardiac diseases in pregnancy, sickle cell disease in pregnancy, syphilis in pregnancy, tuberculosis in pregnancy, diabetes in pregnancy, and HIV in pregnancy. So let's discuss about the first one, which is antepartum hemorrhage, whereby we are going to do introduction and definition of antepartum hemorrhage, and also some causes and diagnosis. Then in the next video we are going to talk about management. So basically, hemorrhage is the leading direct cause of maternal deaths, and it accounts for about 34%. So that's why we take this matter serious. And we say that anemia in pregnancy is common in Africa, and bleeding in pre-existing anemia increases the risk of death, and it can be death of the mother and even death of the baby due to this complication. Then appropriate care in pregnancy and labor should include detection and correction and prevention of anemia. 2, care by skilled attendants, and then recognition of early management of complications. So in this scenario, we define APH, or what we call antepartum hemorrhage, as vaginal bleeding during pregnancy, usually presenting in the last trimester of pregnancy. Any vaginal bleeding after 28 weeks should be assumed to be due to either placenta previa or placenta abraptio, that we are going to define in the next few moments, unless proven otherwise. Now, causes of APH, bleeding in late pregnancy and in labor, is usually due to the two that I've mentioned, that is placenta abraptio and placenta previa. Now, in definition of placenta previa, if we can give some slight explanation, we say that this is when implantation of the placenta occur at or near the cervix. That is a marking point, at or near the cervix, and it may be partial or complete. We are going to look at that. In partial placenta previa, a posterior situated placenta is more dangerous than an anterior one. In placenta previa, bleeding is always revealed, though it may cease spontaneously. The blood color is usually bright red. Mark that one, bright red. Now, the signs and symptoms of placenta previa are as follows. 1, painless bleeding. The mother may bleed and does not feel any pain. 2, blood is bright red and may be scanty or even heavy, as I've said earlier. Pale-looking patient, the degree of which corresponds to the amount of blood loss. No tenderness in the abdomen, that is, in the normal layman's language, there is no pain in the abdomen. Soft and relaxed uterus. In obstetrics, we don't forget to mention uterus when we are doing abdominal examination. So the uterus will be soft and relaxed. The presenting part may be high, or there may be abnormal presentation. The fetal parts are easily palpable, and fetal heart sounds are usually present. Continue saying that this is premature detachment of anomaly situated placenta before the fetus is delivered. The resultant retroplacental bleeding may be revealed, concealed, or mixed type. The causes include toxemia, sudden uterine decompression, and short umbilical cord. Signs and symptoms are as follows. 1. Bleeding. In the revealed type, amount of external blood loss is consistent with the condition of the patient. In concealed type, there is usually little or no visible vaginal bleeding, yet the patient is pale. Mark you, there is in concealed type, there is usually little or no visible bleeding, yet the patient is pale, meaning the patient is severely anemic because it is concealed. There is constant abdominal pain, tenderness on the abdomen, woody hard tensed uterus. Fetal sounds are absent in severe cases. So that one we've discussed about Abraptio placentae or placenta abraptio. Now, how can we diagnose APH? There is a table that I will present into the screen on how to diagnose this, and we have the presenting complaints and other symptoms and signs typically which are present at that time, and then we have the other part of signs and symptoms which are sometimes present and probable diagnosis. Now, if bleeding is after 28 weeks of gestation and there is shock, and the bleeding may be precipitated by intercourse with one man in this, and the uterus is relaxed, and fetal presentation not in lower uterine pole that feels empty, and normal fetal condition, probable diagnosis will be placenta previa. Now, when bleeding may be retained in the uterus after 28 weeks of gestation, and there is intermittent or constant abdominal pain, and the patient is in shock, and there is tender uterus, and it's also tensed, and the decreased fetal movement and fetal distress may be plus or minus, and fetal heart sounds, that one we call a probable diagnosis of Abraptio placentae. Now, the other part that we may introduce in this scenario is when there is bleeding intra-abdominally and or vaginally. Then there is severe abdominal pain, which may also decrease after the rupture. Then the patient may go into shock, there may be abdominal distension, there may be free fluids palpated in the abdomen, and abdominal uterine contours may be very visible, and the abdomen may be very, very tender and easily palpated fetal parts, and even absent fetal movement and heart sound and rapid maternal pulse. Probable diagnosis in this scenario is ruptured uterus. But we also have differential diagnosis of antepartum hemorrhage that we may put into consideration. One of them may be labor, especially when there's bloody show. There may be cervical erosion. Cervicitis may also present. Carcinoma or cancer of the cervix may be a differential, and maybe finally trauma may be a differential in this scenario. So thank you very much in those few notes that we've noted, and in the next video we are going to discuss about management of APH or management of antepartum hemorrhage. Remember, if you have not subscribed to this channel, hit the notification bell written subscribe. Always turn it on so that if we post the next video, you will be number one to watch it. Always support this channel by sharing it widely, liking the video, and put your comments down there. See you in the next video, and muchas gracias.